One is that people want high quality 7-day services. I mean, as if they'd want low quality ones. Integration of mental and physical health and prevention or early intervention. Now, there are lots and lots of other things, loads of recommendations across lots of different bodies within the NHS and government. But essentially, it amounts to £1 billion, or reaching £1 billion for adults by 2021. Now, I didn't have anything to do with developing the 5-year forward. I came in as National Clinical Director after it had been produced. So it was sort of my first thought was, let's try and make some sense of it. So this is what I think are the sort of high-level direction of travel for the 5-year forward. So the first one, I think there's a message that says we are reducing our dependence on institutional responses. Okay, so if you look all the way through it, it doesn't say anything about increasing beds, having more forensic beds, etc., with one exception, which is perinatal. We'll come to that in a minute. There is a new exception which has been added, which is for a short period of time that we are expanding access to Tier 4 beds for children and young people. But that, I must stress, is short-lived. Second thing is to create alternatives to admission. So although we are increasing perinatal beds and building 3 new MBUs, we're also putting a big investment in community services. And that goes across acute care or crisis care and so on. Third point is integrating mental health. Now, you'll see it says integrate mental health in with physical health, and that's very obvious. We'll come to that in a minute. But it's integrating mental health across the board. And that includes thinking about new ways in which we might integrate mental health in schools, in social care, etc. Fourth key point is that we need to be enhancing mental health services right across the age range. So from perinatal services right the way through to older people. And the final piece, which I think runs throughout the 5-year forward view, is that whatever we are setting up, let's set up services that work so that they've got some evidence behind them. Okay, again, this slide is probably pretty well known. 12 boxes, each one a target. And I can't cover all of them. So you'll see at the top left-hand corner, we're saying we're going to see 70,000 more children. And we've got 10% reduction in suicide. We can talk about that. So any of these, but I can't cover them all. There's too much in there. So I'm going to start off with what we're doing about perinatal. So as you can see, 4 new mother and baby units. They've already been identified. They're in areas where currently people have to travel huge distances to get them. We're setting up community-based perinatal services. As we started this, only 15% of the country had perinatal community-based services. So we're aiming to cover, by 2021, cover the whole country. So that's perinatal. Children, as I said, 70,000 more children. Now, sounds like quite a lot. Percentage-wise, that's an 8% increase in the number of kids that we're seeing, okay? So at this point in time, if you go out into the community and you interview children, do a clinical interview with them, you will find 4 times as many of them than you will see represented in CAMS services. So CAMS are only seeing 1 in 4 children who've got a mental health problem. This will bump that figure up to 33%, so from 1 in 4 to 1 in 3. And I'm sure all of you who didn't know that will feel slightly uncomfortable that that's all we're managing to do, and we can talk a bit more about that too. Another one that we're doing is that we're encouraging localities to take over what currently are tertiary beds in Tier 4 CAMs. And the point of that is to try and reconnect institutional responses to children and young people back to their localities. Currently, as I'm sure you know, there are lots of stories of people of kids who are taken sometimes 200 kilometres, 200 miles away from their home to be able to get treatment, whether that's for eating disorders or indeed for kids who've got major behavioural problems or psychosis. So we want to reconnect Tier 4 beds with their local community. And in so doing, move some of those resources back into community services. Okay, so what will that amount to? That'll amount to 35,000 more children over the next year. That will amount to about 170 million investment. I should have said that alongside the aim to get up to £1 billion extra per year into adult services, we are over a 4-year period investing 1.4 billion, 1.4 billion into CAM services. So 170 million over the next year. Now, that 8% increase isn't satisfactory for either Number 10 or the Secretary of State, and the Secretary of State for Health and the Secretary of State for Education are currently working on a green paper to try and see if we can't reach the other 66% that the current plans don't reach. And it was our collective view that the right place to do that would be to go into schools. So the green paper will be about the mental health of children in schools, and obviously we're all keeping our fingers crossed that that will, in the long run, lead to a significant investment into children's mental health in schools, but we are also hoping that schools will embrace that and own it as part of what they do. But we'll see. Green papers, that's not for us to produce, but it is for us to have a view on them. Okay, next one, 60% of people, this is one of the waiting times that we've introduced. 60% of people who have a first episode psychosis should be starting treatment within 2 weeks. Now, we are actually achieving that in large parts of the country. I think we're up at about an average of about 65 to 70% of people being seen. And for treatment starting. So over the next year, that would be 10,000 more people. Now, I should say, interesting fact here is that we made our estimates of incidence, so that's new cases of psychosis, on the basis of the best epidemiological evidence we've got. And it looks like most parts of the country, we've underestimated by about half. So we've got effectively double the number of people than we expected coming into early intervention services. That was not expected. It looks as if, because we're now saying we will help you within 2 weeks, more people are coming forward, which is a big surprise because most of us thought, well, if you've got psychosis, you're bound to come into services. But actually, that appears not to have been true. We're investing, again, most people probably don't know this, we've put £49 million into CCGs this year, starting this April, to go into crisis teams. So in my hometown of Sheffield, that's 1% of the population, so we should have £500,000 approximately going into our crisis teams. I don't think we've seen it as yet, but we can only hope. Another one is a corollary of that investment is that we should have lower out-of-area placements. There are currently 10 trusts around the country who have no out-of-area placements, including my own, for the last 3 years. So we are going to help all the other trusts, all 46 of them, to get their out-of-area placements down to 0 within 3 years. Oh, I'm ahead of myself, so I'll skip that. Nearly coming to the end. Currently, people with anxiety and depression, we see 15% of people who have anxiety and depression, adults, in our IAPT service. Doesn't mean to say that GPs don't see lots of others, but in terms of getting psychological treatments, which are the first port of call in NICE guidance, only 15% are getting that. So there's a big investment to increase the number of therapists in IAPT by 3,000, and that we expect will increase our reach by 10%. So 25% of people should be seen, and that will be focused on 2 groups that currently don't get much in the way of psychological help: people with long-term conditions who have high rates of psychological problems, and people with medically unexplained symptoms who currently cost about £3 billion to the NHS. A third of people going into acute hospital outpatients turn out not to have a physical health problem, but have a mental health problem. So that's what we've done with those. Over the last year, 600 new therapist training, etc. And we are hitting our targets in terms of waiting times for IAPT. Okay, then in other areas which I don't have time to go into, and I think I've run out of time now. Okay, a couple of minutes, okay. New models of care in forensic services. So one of the things that I did in my trust with colleagues, lots of us did it together, was to find all the people who'd been in forensic care and then put into locked rehab, and then we brought almost all of them back. Some have remained in institutional care that we've brought them back to, but the majority, vast majority, we've put them into the community with standard tenancies and used the huge amounts of money that are tied up in forensic and locked rehab to invest in ultra-intensive community treatment teams that provide care 24/7. Okay? Now, we want to do that with all the forensic ones as far as we can. That's not taking people who are currently very dangerous or currently harming themselves greatly and just dumping them in the community. It's gradually helping them reconnect with the community from where they've come. So we're doing that with, as I say, Tier 4 CAMs, but also forensic across the country. I mean, I don't know if you know, but there's forensic services, a £1.1 billion spend currently, so that's not huge numbers of people. And alongside that, there's locked rehab, which is about a £900 million spend. So we're talking about £2 billion on institutional care that we think we could spend better on community-based care, backed up by some institutional responses. Digitalisation. We've set up 7 global digital exemplars. Each have got £10 million. That's going to be followed, we hope, by some more investment to get mental health up to speed. Now, I say up to speed, mental health is probably ahead of most of the rest of health in terms of getting everyone with an electronic patient record and using digital innovations. So we want to spread that. And I'm chairing a NICE digital therapies committee, which is going to start putting out by the end of this year, we'll be putting what are called blended digital therapies out into the NHS. So there'll be a combination of face-to-face work, and then between face-to-face times, you'll do digital work. As I say, out-of-area placements, that's locked rehab, Tier 4 CAMs, but also acute, so we want to get all of those down. Suicide prevention strategy, which I imagine Gregor might say something about. And we should, by the end of, by April of next year, start investing £25 million to bring the suicide rate down by 10%. And then there's lots of incentives in the system. So I'm going to call it a day. You'll be able to get my slides. Those are the key issues. If you want to ask anything about them, these are the risks or the problems that we think we're going to face in getting all this into practice. So please do ask questions later. Yeah? Okay. Thank you.
Thank you, Tim. And it's great. I remember seeing some of the presentations about the 5-year forward view when it started, and it's really fantastic to see that we're getting progress in many of those areas. But also a reminder we've got quite a lot still to do. It won't all be finished by the time we get to the end of the 5 years. There'll be a lot more to do in mental health, but what an enormous amount we've still got to do. So no pressure. I should mention, as Tim suggested, that all of the presentations will be available afterwards, and this is being videoed, so you'll get a video of everything you've seen today, which you can share with colleagues. So you don't have to write too many notes unless you want to. So just so that you're aware, and without hesitation, we've heard from NHS England and NHS Improvement, 2 for the price of 1. So I'm really pleased we can now hear from Public Health England and from Gregor Henderson, Director of Wellbeing and Mental Health. And I think particularly on that hugely important area, the biggest health inequality we have in this country, I think, physical health of people with mental health problems. So Gregor, the floor is yours.
Thanks, Andy. Thank you to the organisers for inviting me. Thank you very much for coming to this conference. I'll say it before someone else does. I don't feel entirely comfortable being one of 5 men in grey suits on a platform talking to you. No disrespect to my colleagues, but I think we've got a bit of a gender imbalance. So that out the way, let me say the conference is extremely ambitious. I was looking at the programme. We're talking about the future of mental health, workforce, children and young people, secure care, CBT, digital, supported living, occupational health, substance misuse, local councils, and perinatal. It's a real cornucopia of challenges and opportunities. So I'm slightly wondering how my presentation on the physical health of people with mental illness is going to land. But what I want to really do is to say that I'd like a broader conversation when we get the chance to speak in the panel. And can I just do this because I can't help it? My mother was a school teacher and I love to see a show of hands. Can I just check to see who is in the audience so I know who I'm speaking to? It's dark out there. But I think I'll see your hands okay without the lights going back on. So who here works for some kind of healthcare provider, and that includes a digital provider? And who works for local government or public health? Great. And the voluntary and community sector? Wow, by far and away the largest sector. Research and academia? Great. And some of you have put your hands up more than once, which is great. And anybody else I've forgotten, I apologize. And you can tell me afterwards, not during the session, about where you're from and what you're doing. Okay, so let me just move on a little bit. So I work for Public Health England. We are your national public health agency. We do a lot of work around health protection, health improvement, data evidence and knowledge. We are an agency of government, but we provide independent evidence and advice to government and the sector. Our main audience is the public health field, however you define that. So we would categorize everybody in this room as someone who has got some public health expertise and some public health knowledge. And our aim really is to improve the public's health and reduce health inequalities. In the mental health brief, what we try and do is make sure that mental health is something that all of our areas and functions are doing, whether it's emergency response to disasters or outbreaks and the psychological effects of things like flooding and disasters and emergencies, or whether or not it's looking at coronary heart disease or diet and obesity. There's a psychosocial element to everything that we do. So I think it's very important that we don't just see mental health as defined by mental illness, although that's extremely important, that we are much more sophisticated in the way in which we think of mental health. And I'll say a little bit about that before I close. So this is the kind of work that we try and do in the mental health team, along with many, many other of our colleagues across Public Health England. So we are trying to do work on mental health promotion. We're trying to do work on mental illness prevention and suicide prevention. And that has basically been the majority of our work over the last 3 to 4 years. So some of you in the field may know a lot about our suicide prevention work, that we've got a whole set of resources and guidance, particularly the guidance on every local area having a suicide prevention plan by the end of this year. So if you want more information about our guidance, just Google suicide prevention, Public Health England. All of that will come up on a page. We've also just published the Prevention Concordat for Better Mental Health, which looks at promotion and prevention across the life course. And we've published a suite of 10 documents, reports, and guidance and tools, including a return on investment, so you can choose which areas you would like to invest in that we know will give a return. And that was published on the 30th of August. If you Google Prevention Concordat for Better Mental Health, that will come up. So a whole series of things. The area that we haven't given enough attention to has been improving the physical health and well-being of those living and recovering from mental health problems. That's not because we haven't wanted to do. It's a question of putting resources where we know we can actually legitimately begin to do something. So we've been having lots of conversations with NHS England, all across our organisation in terms of those working on CVD, on screening. And we now have been looking at ways to which we can collect data. So we've got a base point of where we are with this, and that we can actually monitor progress as we go on. So it's not an excuse, but there are some reasons why we're now coming to this. And we are appointing a senior person to lead this work very shortly. And we are very encouraged by our partners' reactions to that, and working very closely with NHS England and others. So this is an area that is the next big priority for us in the national team. Some context. You don't need me to lay out just how gross this inequality in the physical health of people with mental illness actually is. But they're dying from the same things as everybody else. So are we going to look at integrated solutions, or are we going to continue to put things in a mental health, mental illness box and magically expect that further exhortation of the inequalities is actually going to shift things? Whilst we talk about evidence and data and indicators, what we really, really need to see in this area is action. And I think there are some elements of the jigsaw that are in place already, and we need to drive those incentives much harder. But I think there are some things we are really missing that would make an absolutely big difference. We can't talk about the health and well-being of people with mental illness who will increasingly have comorbidities unless we start talking about employment and unemployment, poor housing and homelessness, and the still very, very prevalent stigma and discrimination. So the wider psychosocial determinants are as important as what we might be able to do in services and in public health screening and supporting. So this is that kind of complex agenda. We can't just expect, as we've got, thankfully, more resources coming to the NHS, that they will be able to deal with all these issues. If you're sitting in front of a client who has long-term and persistent and significant mental health challenges, unless you're looking at the wider context of their lives and their ability to function in the ways they wish to function, any amount of sequins or any amount of QOFs aren't going to improve employment status, housing status, relationships, being debt-free, and having those amongst them who love and care and support them. So we need to look beyond diagnosis into functioning. So the 5-year forward view states very clearly that this is an absolute priority, and that we need to do much more to make that clear. Whilst it's a 5-year forward view, it really is now a 3-year sprint to the 2021 finish. So it's feeling like we need to start thinking about what comes after the 5-year forward view. And it would be great if the 5-year forward view expanded into what over a quarter of people said in the consultation on the Mental Health Task Force is we need to get much more upstream, and we need to be much more active in the psychosocial elements of this and addressing the wider determinants. So this is good, but we need something that will follow it very, very quickly. So these are the areas that we have a lot of activity in, promoting equal access to cancer and all the other screening programs. We know that for some, people with mental health problems are getting just as good access, and for others we know it's woeful, and we need to do much more to do that. We've got some baseline data on that coming out soon, so we can actually measure and track the extent to which our screening programs are being much more active in actively engaging people with mental health problems and making it easier for them to access screening services. Promoting physical health care, the sequins and the QOFs, very, very important, very much NHS job and also the job of primary care, but we can hold some of the evidence and the data to that to make sure that those are happening. Smoking cessation, we've had a massive amount of guidance on smoking cessation, and we now need to make sure that all mental health units across the country are smoke-free by 2018. We'll publish an atlas of variation, which isn't a naming and shaming, but it's just showing which trusts across the country and which facilities are smoke-free, so we're actively working on that. And I've stressed again addressing wider determinants and that we provide system support to do that. There are a number of areas which I'm going to rattle through, but the NHS Health Check is really, really important in this. And we need to make sure that people with mental health problems have as equal access to the NHS Health Check as others. And with your help and others, we are still trying to drive some form of questioning, some form of attribute within the NHS Health Check that actually asks about mental health and not just concentrates on the physical health aspects. And we're moving slowly and surely towards that, but we do need some better science to get past some of the scientific committees that judge what goes into NHS Health Checks and what doesn't. So lots of opportunities here to do something more and better. Can I also say on NHS Health Check and CVD initiatives, we'll be doing something a little bit further, but I'll say something about that in a moment. The other areas are the recommended physical health assessments for people living with serious mental illness. There is a very, very variable picture across the country, and what we'd like to do is try and collect the data and information so we can actually show the variation. In some parts of the country, 90% of people with severe mental illness are accessing sequins and physical health checks. In other parts of the country, it can be as low as 10%. And that inequality in access on this very, very important health check is really unacceptable. So we need to find ways of ensuring the system is doing what the system is asked to do. Primary Care Commissioning Guidance, NHS England will be publishing that soon. And we really do hope that will make a major impact in terms of the primary care's attention to addressing this as best they can. And I think going forward, we want a lot more work around the alcohol and drug comorbidities. We've got lots of guidance, and might want to pick some of that up in questions for those who are interested in the substance misuse angle. And tobacco, I've said an awful lot about before. I'm ripping through these slides because you'll have these to take away. But we do need to make sure that we are addressing smoking cessation and tobacco within mental health and mental health units, but also finding ever more innovative and outreach ways to reach people. So the smoking and mental health program has a number of different attributes to it, but as I said earlier, we really do want to make sure that all the providers are smoke-free. So opportunities, great opportunities going forward, learning from other places. Andy at the Centre for Mental Health Rethink and lots of other colleagues are beginning to look at an equally well collaborative based on the work in New Zealand, which has a shared consensus statement and agreed actions that we can drive into the system. We need to improve data collection and its use in relation to how many people with mental health problems are accessing the things that they have access to. And we also need much more transparency on whether or not people are actually undertaking the guidance and the mechanisms that are in the system to help make sure that these things happen. So we do want to see more emphasis on smoking cessation, the physical health sequin, and primary care physical health. In relation to Public Health England, we've also got some work coming out from the right care work. There will be some guidance on severe mental illness and CVD. That will be produced in March 2018. And my colleague Carly Woodman, who is here and is just about to wave her hand, just up there on the left, will be here all day. I'll be here till lunchtime. We'd love to speak to those who are working in CVD and SMI and get a little bit more opportunities going there. Before I finish, what I would like to say is that there is so much going on in mental health at the moment, which is absolutely fantastic. I think that we need to, in terms of the work going forward, we need to be much, much sharper at differentiating between what we're doing for good mental health, what we're doing to support and respond to people who are experiencing mental distress without biomedicalizing and pathologizing everyday events. And we need to make sure that we are reaching out to those with mental illness in ways that boost and support their recovery. That can't be done without a psychosocial approach. We can't expect the NHS to solve all of the challenges, and we really do need to start working as one system to make the whole thing work more effectively. So whilst the NHS has got a significant investment to improve services, we are also asking councils, local government and other colleagues to make sure that we don't stop just with an investment in mental illness treatment services. Otherwise, the whole system doesn't work together. We need more research, we need far more implementation, and we need much more implementation science and living ways, if you like, living laboratories of making sure that the things we're doing are actually having impact. And we also need to activate the public more, and we need to have a much more sensible dialogue with the public about what mental health is, what mental distress is, what mental illness is, and what we can do to support not just ourselves and others. So it's a very, very wide agenda. I hope you enjoy the rest of the conference, and I'm looking forward to our conversation in the next 15 or 20 minutes. Thank you.
What I've realised is not only are there too many men at the front, there are literally too many men in the front, and we don't all fit on those chairs. So apologies for the time it takes for us all to walk across here. There will be greater gender balance over the whole of the conference, I'm pleased to say. So I think during the day there will hopefully be a range of speakers. Just incredibly important there, I think, to hear about physical health and really thinking of it, I think, as a rights-based issue here. That actually people who happen to have a mental illness do have a right to good physical health support, and seeing that in its full context. So it is about employment, it is about money, it is about housing, it is about the things that affect our lives, as well as the health checks and the other things. I also think the infographic on the health checks was one of the most adorable I've ever seen. We have got a varied session this morning. We're covering lots of different areas. There will be a chance for questions and comments to all of the speakers before we have our rather generous coffee break. So hold on to those and think about things you want to ask, and if you want them to be challenging, that's all right. But before we do that, we have double act, which is rather exciting. So Cass Hack and Patrick Neville from Elysium Healthcare. I think picking up one of the themes that Tim was particularly talking about specialised services. So really pleased we can get a bit of detail on that, and the floor belongs to both of you.
Thanks, Andy. In the limited time, I think I want to approach this subject really from a couple of perspectives. Firstly, as a medical director of a national provider of mental health and neurological services, and we've been engaged in new care models and the programs from Wave 1 last year and with the current wave, and working in closer collaboration with a range of providers, including community providers. So we've got some insights, I think, from the actual realities of delivering these programs, I think, from the ground up. I'm also chair of the Forensic Quality Network, and one of the things that we really try and do there is to encourage providers to maintain high quality standards by sharing best practice and collaborating better. So again, this is an area that we've been actively involved with. I think stepping back, and I do get to see a number of mental health systems internationally, and I think there's a lot to celebrate about what we've achieved in recent years. And I think fundamentally, one thing that we often forget is actually we operate within a legal framework that is actually, in terms of mental health law, is humane. And I think we've maintained that in terms of enshrining principles of making sure people get the right access to care, that we recognise that mental health needs are varied and broad, that we try and enshrine principles of least restrictive care, and also when liberty is necessarily restricted proportionately, that there are safeguards in place to make sure that's appropriate. I think we often forget that, but it's important. Related to that is the fact that we recognise that needs are broad, and actually a lot of the challenges we have as services, and I'm just thinking about some of the variation that's been presented this morning, is because individuals do change and individuals can present to services at what may seem as inconvenient times and inconvenient locations. So as we develop new programmes, we need to recognise that. We also have, of course, many years of learning from attempts at service transformation. I think a colleague reminded me recently of Enoch Powell's Water Tower speech in 1961, and there he was painting a picture of a mental health transformation in the 70s, and the grand plan was to reduce beds by about 75,000 and increase community provision. And since then, I can think of a number of projects that I've actually, remember from my professional life, including accelerated discharge programs from high secure care, creating enhanced medium secure units for women transitioning out of high secure, the numerous community reconfiguration projects for teams, and of course the very important current work around early intervention for children and their families. But looking now at outcomes and forensic services, and I'll particularly focus on forensic, if I may, among specialised, but looking at that now in terms of delivery, service models, and where we actually do have outcomes, there is variation. And that, I think, is driving the ambition around new care models and recognising that actually pilots can be different. Our early involvement was actually in the southwest in Wave 1, and there, really the narrative was actually an undersupply of specialised beds locally. But alongside that was the need that community provision was relatively impoverished, and also where there was best practice around community models, for example, around personality disorder and intellectual disability, it had remained local and hadn't extended beyond the local footprint, despite really good evidence that we just hadn't been able to have systems in place to fully accommodate. So really the 5-year forward view is really trying to tackle variation where there is an inequality. And I think it's important not to forget the drivers for those inequalities, because they're the challenges we have to face. I think these are just personal views, but one driver are the problems with the Health and Social Care Act and elements of it in terms of allowing seamless movement through pathways, and I think there have been challenges, certainly within specialised services. I also think from personal experience that providers sometimes get torn between different transformation plans, policy after policy, and I remember as a clinical director dealing with the accelerated discharge programme, creating new service lines for forensic clients in medium secure, and then having a new personality disorder strategy to implement a few months later, and it's difficult. It's a challenge. And then fundamentally, I think it's about how can we commission more smartly. We have a number of slides that are in the pack, but I think I just want to pick up on one. And I think Tim alluded to it earlier on, which is really the growth of secure beds over recent decades. And this shows medium and low secure beds. But of course, there's another strata of secondary commission beds, non-secure beds. And there's a lot of story behind this, but I think what you can fundamentally say is that this growth or this commissioning hasn't been linked to local need. And I think what's exciting about new care models, if we get it right, is its ability to plan locally, regionally, to meet local need and to make sure that individuals actually get the right care, the right place, the right time. I'm now going to hand over to Patrick, who's going to talk about some of the mechanics of the programme.
Hi everybody. I should say my background, I'm a mental health nurse, and I work in strategy, and I've worked across the NHS and the independent sector for the last 30-something or other years. And I used to work in NHS England for a while as well at the start. The 5-year forward view came out of an awful lot of work trying to fix the Health and Social Care Act in some respects, because it was a process of trying to return local autonomy and local control to a pathway specifically in secure care that had been disrupted. I think my colleagues already mentioned the fact that there was an awful lot of spend in secure services, and there's this historical development in terms of capacity to meet need. And that capacity not necessarily always being to design need, it's more of a capacity-led process in terms of trying to find placements in a healthcare sector across the last 10 years that has seen significant changes both in inpatient settings and various other types of services, which has pushed some people who can't fit within normal locally owned pathways escalating into secure and non-secure lot rehab type settings. That's a discoordinated and an overall suboptimal way of managing the healthcare system. One of the things that the New Models programme is about is returning both the responsibility to a regional patch, but also the funding to a regional patch. And those things linked are significant change, I think, from previous ways of addressing system change. The actual money is being delivered to the people making clinical and strategic and operational decisions about the service design against a population need. And then in that sense, it's actually very welcome. So what's being tried within the New Care Model programme for secure services, the overall theme is to have fewer, more effective beds. And to do that, to actually bring out some of that capacity that's been placed across the country, meeting lots of competing aims, but mostly around providing capacity to bring that resource back into meaningful population levels. Not everybody will come home because there is complexity within that, but within the communities of a regional level, such as the Southwest, the ability to provide design services to meet that population's needs right through to community, including prevention, including alternatives to admission, that improvement to the pathway, I think, will provide us with a huge amount of benefit going forwards. Because the money's linked to that decision, that resource release is going to fund alternatives. And those alternatives across most of the new care models are community-orientated services to prevent escalation into pathways and to ensure people move out. It shouldn't be forgotten, really, that no one in forensic services is, we don't make them in vats. These people aren't grown somewhere. They're all local people. They're local people, and in all my career, I've never met anybody who's had a normal, subtle, quiet life. They've had complexities all their life. Their need for care and their need for provision of care has been something that's gone right through childhood. So it's very rare that you meet anybody who's had a spotless, unblemished, almost sugar-coated lifestyle. These people are complex, and they had complex lives from the start. They're also, coming back to the physical health care, challenged in the sense that whether or not the mental health component to access to mental health, to physical health care has been an element, and it certainly has, but their life has been an element. Their integration into local society, their integration into accessing services all through childhood into early adulthood has meant that when they come into specialist forensic services like ours that have primary care services, their needs are extremely high. They've got poor dental care, they've got poor track record of physical interventions and monitoring. It's not their mental health that's kept them, it's their lack of attachment to society overall. And that shouldn't be forgotten. And new models of care can work on that because it's bringing back local ownership to the whole pathway. So it integrates the whole thing within normal boundaries. We shouldn't forget also that NHS England did something over the last few years that was quite important. It's worked with the Quality Network to develop national guidance, it's created specifications for services, it's better defined what those services are, and it's those positions that give us an opportunity to move forward with some coherence around what these services are, and hopefully address some of the nebulous things that exist within mental health settings, such as lot rehab, and what that means as a service description and as a reality. But will it work? And that's a real issue, I think, in terms of I've been through quite a few changes in the health service, and it depends what you mean by working. First of all, how will we know it works? I have to be honest, and it's something that we can be very clear about, is that the data and financial information available to the new care models at their instigation was shockingly poor. So in terms of comparison going forwards, there is a real data issue there. Outcomes and review. To only really compare improvements going forward, we need a consistency of approach to those outcomes, and the new care models themselves are working along with the national team to develop a set of outcome measures that will be able to support that process going forwards. But the basics, again, are admirable, and they're about needing to work, aren't they? Improving their work. What I suppose remains a concern is, does the funding work fully to help this new model process? There is no major pump priming to enable things to actually be loosened up and set in motion quicker. They have to release resources by releasing resources, and the alternatives may not necessarily be in place. But what's being tried is important. So the key thing is out-of-area placements being reduced. And that's meeting both national targets, but also that's how the resources are going to be released. The expectation is that for most people, the capacity redesign approach will allow people to come home within meaningful geographical locations, and to be seamless to their local pathways. The funding is being transferred from NHS England to the New Care Model partnerships. That in itself will help support the programme going forwards. It's important to remember that the funding is outturn and not just budgets. Budgets are almost always being overspent. You can't make a new model work if you're going to actually hand over an overspend to people trying to redesign a service. That would be worse than having no pump priming at all. To invest more effective pathways within a home area. So this is not a bed-based approach. This is actually fewer, more effective beds. Some areas have a capacity shortage because of historical commissioning decisions. Some areas have a massive over-provision of capacity. That movement of design and reorientation has to be controlled, and there's a big programme of work in NHS England around designing a new service model in terms of a capacity need approach. But achieving design improvements for the care, it requires an overall pathway approach. This isn't just about forensic services working in a forensic bubble. This has to work alongside Transforming Care Partnership, has to work alongside the local strategic development areas, it has to work alongside CCGs, with local authorities, with housing and everything else. And all the new care models are looking towards developing relationships locally to enable that to happen. Improving viable alternatives to beds, overall reducing capacity there's good evidence that we've got from this other projects that have happened over the last few years. An example being Pathfinder, which was a model that in the southwest again, that enabled the management of the serious PD population to work in a different way to looking at a bed-based approach. It works across boundaries, it works with probation, it looks at sentence planning, it provides treatment in different settings. Those type of approaches have, with forensic people in them, have had better impacts in terms of providing a better place for care to happen, with people taking responsibility for their life choices and their life situation, enabling support to be wrapped around them. And they're really good examples. There are other examples of good community forensics, assertive team approaches that the new care models are hoping to build upon. Sorry, okay, I'm going to go for it. So will it work? So I think yes, a success, yes. It's going to work because it's doing something that's actually quite important. It's giving money to services, it's making it locally owned again, it's giving a needs-based approach the chance to work, and also it's taking away 5 years of basically static inability to develop services or alter because of an NHS moratorium on service development and secure services, bringing that to an end. And in that alone, it's worthwhile. It's going to reduce travel distance for people. It's going to have care and treatment provided within regions. It's going to develop local pathways, and it's going to reduction in secure beds. It's going to have outcome measures in relation to either direct improvements in terms of patient experience, length of stay, proxy measures, I should have said, such as length of stay, reoffending, etc. Service user satisfaction is at the core of most new care models' outcome approach. And I suppose the bit I would say most of all for service users themselves is that the speed of this programme, the speed of its implementation, the speed of it becoming a reality is that the service user voice at the start has been not as heard as it should be. The new care models, all of the ones I'm aware of, are committed to making that work better, to make sure that that's fixed as quickly as possible. But we shouldn't forget that those voices have been heard because people have spent decades asking for care closer to home, to reduce travel distances, to have their needs met more locally. And at the core of this programme is the ability to do that.
Thank you both very much. I'm glad these microphones work. I didn't want to have to go and stand at the podium again. Three really different, but I think I'm trying to find a link between them, and the link between them is we're talking about some deeply entrenched, incredibly important, lifelong, I would say, structural inequalities in health and healthcare that actually this strategy we've got over the 5 years is aiming to, at the very least, begin to make some change in and beginning to make some progress. And we know we won't be finished and everything will be done by 2021. But clearly some really important work happening to help us towards that. This is the bit where you get to either ask questions or make comments. There will be roving microphones, so if you could indicate that you'd like to say something, and I will come to you roughly in the order in which you put hands up. I've seen 3 already, so that's a very good start for. If we could have the person right in the middle there, and the microphone is coming towards you.